Integumentary. Let's look at some terminology. Hematoma. This is a mass of accumulated blood under the skin. You may be able to actually palpate a firm area or an enlarged area where this blood has accumulated. Ecchymosis. This is bruises. Erythema is a reddened color to the skin. Pruritus is itching. Urticaria are hives. A hemangioma, these are those flat purple marks. Often we'll see them present at birth. Angiomas are going to be bright red round papules. Petechiae, these are pinpoint brownish to purplish colored lesion. They almost look like little teeny tiny bruises. So as we're interviewing someone who is complaining of skin issues, we ask them if they have noted any skin changes lately, and if so, what are they? Do they have any itching? Have they noted any redness or rashes anywhere? Have they changed any soaps or detergents? Bought new clothing that they have not laundered prior to wearing? Have they eaten new foods? Are they taking new medications, etc.? Ask them how much time they spend in the sun and what methods they use to protect their skin. And of course, we want to know if there's any family history of skin diseases or skin cancers. So as we do that skin assessment, we want to inspect it. We're looking at the color. Do we see cyanosis, which is that bluish discoloration, erythema, jaundice, which is the yellowing of the skin, pallor, meaning they're very pale. Is it pink? Is it mottling? Mottling is like purplish discolorations. It's really easy to see in light-skinned people, especially when they're cold. You look at their legs and you see kind of these purple discolorations over their entire leg. That's what we call mottling. If we see it in someone who is acutely ill, this can mean that they are not getting enough oxygen to the tissues. In the darker skinned people, to assess color, we may need to look at their mucous membranes and or their nail beds. Mucous membranes are going to be the best, but nail beds could also be assessed. Do you see any bruising? And this includes the petechiae. If they have bruising, it's important to determine what medications they're taking or ask them how they potentially got the bruise and see what their answer is. Maybe they fell, maybe they just bumped it against something, but we always want to consider the potential of abuse. Do they have varying pigmentation, such as freckles or moles, those hemangiomas or angiomas? Do they have lesions? And this includes rashes and any type of wound. Do they have tattoos or piercings? And if so, what size are they and where are they located? We assess their skin turgor. So we're determining the hydration of the skin, hydration of the client. Make sure that you check that on the forehead, the sternum, or the clavicle. Assess the temperature of the skin, the texture. Is it smooth? Is it really rough? Is it dry or is it cracked? Is it moist or clammy? And what is the hair distribution? This is especially important on the lower legs. So when you are assessing hair distribution, uh, look at the lower legs to determine if it's thin or we have a normal distribution. There's adequate hair growth. If we have thinning of the hair growth on the lower legs, this can indicate a circulatory issue. So now what do? We need to do client teaching, and we're going to teach about things such as how to protect the skin when they go outside, making sure that they're wearing an adequate sunscreen with at least 45, 50 SPF to it, making sure that in the summer where the sun is strongest that they're staying out of direct sunlight between 10 a.m. and 4 p.m. if at all possible, covering the skin, making sure that maybe they're wearing a hat, or if they have to be outside, that they're in the shade. Staying well hydrated, keeping the skin moisturized, teaching them about their different medications. There's some medications such as the anticoagulants that clients are easily bruised. There's other medications that can cause some issues with the skin, and we need to make sure that our clients know about this. If the client is prone to pressure injuries, we need to teach them about offloading. So let's get the weight off of that particular area. Avoid any triggers that may cause skin issues. If their skin is really dry, maybe they should bathe less often or use a warm water instead of hot water. Some of the diagnostics that we may implement would be just the visual inspection. That is the primary method of diagnosis. It may require a culture and sensitivity test if we suspect there's a bacterial infection. We may do allergy tests to determine sensitivity to one or more allergens. A Woods light uses a black light to help identify certain fungal infections. We can do potassium hydroxide tests to identify other fungal infections that are not observed with a Woods light. We can then do a fungal culture to determine the type of fungus. A skin biopsy would remove tissue for microscopic examination. And there's 3 types of biopsies that are done for skin biopsy. We can just scrape a lesion with a scalpel or a razor. We can excise part of or the entire lesion with scissors or a scalpel. Or we can use a punching instrument that removes a core of a lesion. There's 4 different descriptions for skin color when we're talking about the skin. Pallor, it's very pale or white, but in brown-skinned or darker skinned people, that pallor may be exhibited as a yellowish brown color, or ashen in black-skinned people. Again, remember to look at the mucous membranes, the lips, or the nail beds. Erythema is that pinkish, abnormal pinkish or reddened color. Cyanosis is a blue color. And jaundice is that golden or orange or yellowish color of the skin, often seen in the whites of the eyes. If you look at your slide, this indicates the different types of lesions that we may see. The macule being very flat, The papule is going to be more of a raised area on the skin. Several different ones here to become familiar with. As we assess a wound, we have to use our senses when we're doing that assessment. First of all, our eyes. What does it look like? What is the color of the wound bed? Do we see any swelling? Is there any exudate, also known as drainage? We touch it. Is it warm, abnormally warm compared to the surrounding skin? Is it soft? Is it boggy? Kind of squishy means boggy. Is it firm? Does it have an odor? And when we're assessing odor on a wound, first of all, we have to clean it. And we clean it with a normal saline. And once it's been cleaned, then we determine if there is still an odor. A lot of our dressings today are designed for extended wear. In other words, they can stay on for 5 to 7 days. And in this case, if you consider, we have this wound that's been covered, there may be some exudate there, it's been sitting there for days, it is probably going to have an odor. So we always want to clean it first before we determine if there is an odor. Then we listen for complaints. Listen for moaning or groaning. Do they catch their breath when you touch the wound? Those all help assess for pain. So first of all, we're going to measure the wound. And we measure the wound using the wound as a face of a clock. So the head will always be 12 o'clock. The feet will always be 6 o'clock. The right, and this is your right, not the client's, will always be 3 o'clock. And your left will always be 9 o'clock. When we do our measurements, the 12 to 6 o'clock is always the length. That is the first measurement we get. So head to toe, length, first measurement. Then we do our width, which is going to be side to side. So 9 to 3 o'clock. This is our width, second measurement. And then we do our depth. Our depth is going to be the deepest point of the wound. We place the tip of a sterile applicator in the deepest part of the wound, place our thumbnail parallel to the edge of the wound, and mark the sterile tipped applicator with our thumbnail at the area that is parallel to the edge of the wound. Pull that sterile tipped applicator out, and then we measure it on our measuring tape. And I'll demonstrate this in class, so this just kind of gives you a heads up on how we're going to measure the wound. Wounds are always measured in centimeters. Then we determine, is there any undermining or tunneling? Undermining is going to be where the wound edge is not adherent. So we can take a sterile tipped applicator and actually run it around the edge of the wound, and if it goes under the edge of the wound, then we have undermining. Again, we would describe this according to the face of the clock. So let's say I'm doing a measurement and I'm checking for undermining. I've noted that there's undermining, in other words, my sterile tipped applicator goes under the edge of the wound from 7 o'clock to 11 o'clock. And when we're measuring, we're reporting those, we always go clockwise. Because if you go from let's say I just said 7 o'clock to 11 o'clock. If I were to say 11 o'clock to 7 o'clock, then that means from 11 all the way around to 7, we have that area with undermining. But that's not what I meant. I meant from 7 o'clock going clockwise to 11, that area has undermining. Then I measure that undermining the same way that I measure the depth of the wound. I put my thumbnail at the edge of the wound. At the deepest part, you're going to put your thumbnail on the tip of the applicator, then measure it on your tape. Tunneling would be just what it sounds like, a tunnel. Again, we describe it at the area according to the face of a clock, and then we measure the depth of it. We need to identify the wound bed tissue. We have epithelial tissue. Epithelial is partial thickness, and it's pink. So this is like if we get just a very light scrape, that would be epithelial tissue. Granulation tissue is full thickness. This is a beefy red tissue. It kind of looks almost like hamburger. Slough is what we call a non-viable tissue. It's a dead tissue. It is full thickness. It can be yellow, white, tan. It can be moist. It's usually adherent to the wound bed. So it kind of looks like maybe a wet scab or pus, but you try and clean it off and it doesn't go anywhere because it's adhered, it's stuck to the wound bed. And the fourth type of tissue is eschar. This is also full thickness. The tissue is usually black or dark brown. It can be very hard and dry or leathery, or it can be really soft and moist. But again, usually black or dark brown. Often adherent to the wound bed also. If it's soft and moist, sometimes it will kind of slide around on the wound bed. We then need to assess the peri-wound. So we're talking about 4 centimeters around the edges of the wound. We're assessing the exudate. Let me go back to the peri-wound. So 4 centimeters around the perimeter of the wound. So we're looking at the integrity of the skin, the color. We're feeling for any induration. So is it kind of firm and hard around those edges? And we're feeling, is it warmer than the surrounding skin? So we're assessing for edema, erythema, induration, and warmth. Then the exudate, or the drainage. We need to know what it looks like, how much there is, and is there any odor. So a serous drainage is that clear or light yellowish drainage. Kind of looks like body fluid, or if you puncture a blister, that's kind of the fluid that comes out of a normal blister. Sanguinous is blood. Serosanguinous is a mixture of serous drainage and sanguinous drainage. So it may look like blood, but it's just kind of watery and thin, or it can be just pink tinged. Purulent drainage is that pus. It's opaque, you cannot see through it. And we can also have a mixture of sanguinous and purulent drainage. Excuse me. We need to assess for signs of infection that would include erythema, warmth, purulent exudate, edema, and increased pain. And we assess for pain. Are they verbalizing pain? If so, then we need to try and get that numerical scale. But remember that moaning or groaning or crying or yelling, are they pulling away, withdrawing? Are they grimacing? Are they guarding that area? Those can also be indicators of pain. Skin tears. These are traumatic wounds that are caused by mechanical forces, and it includes removal of adhesives. This is the definition that's provided by the International Skin Tear Advisory Panel, and they classify their skin tears. There are several different classification systems out there, but I don't know about you, but I prefer to use the most simple but most comprehensive system. So the one that I prefer is the new simplified International Skin Tear Advisory Panel classification. They have type 1, which means that there's just a tear in the skin, but there's no loss of skin. We may have a linear or flap tear that can be repositioned to cover the entire wound bed. Type 2, we have a partial skin loss, and that's kind of what we're looking at in this picture. The partial flap can be repositioned to cover part of the wound bed, but not the entire wound bed. Type 3, we have a total flap loss. So the entire wound bed has been exposed. The common causes of skin tears are shear, friction, or blunt trauma, and they can occur on any part of the body, but usually on the arms and the legs. They are particularly common in populations that have fragile skin, such as the elderly, the chronic or critically ill, neonates, and some of our pediatrics. So it's really important to prevent skin tears, so we create a safe environment for the individual that minimizes the potential of bumping or knocking into furniture. If necessary, we can pad or protect those extremities. Maintaining skin integrity through consistent skincare regimen and proper nutrition and fluid intake. Make sure that they wear protective footwear and clothing to help reduce the risk of injury, and ensure safe patient handling techniques are being used to help limit the risk of injury and minimize the use of adhesive products on frail skin. So main goals when we're talking about treatment is to preserve that skin flap if possible and protect surrounding skin. We reapproximate the edges without stretching it too much, and we can do this by using a moistened cotton applicator. Protect that site to reduce the risk of infection and further injury. When you select a dressing to use on a skin tear, we look for one that will allow for atraumatic removal. In other words, we're not going to reopen the skin tear when we remove the dressing. We want there to be an extended wear time and moist wound healing. If you cannot see through the dressing, then we encourage using an arrow on the dressing to indicate the direction that the dressing should be removed, so we're not disturbing that flap. And as always, we would monitor the wound for signs of infection such as pain or increased exudate, swelling, heat, erythema, or odor. And these are the different types of tissues that you may see. As you look at the upper right or upper left picture, this is a picture of epithelial tissue in the lower left portion of the wound. In the upper right portion of the wound, that's more of a granulation tissue. If you look at the middle upper picture, this is granulation tissue. Once again, this kind of looks like hamburger. It's that beefy red color. This epithelial and granulation tissue, these are healthy tissues. This is what we want to see. The upper right, this is a picture of slough. Again, it kind of looks like a wet scab or pus in the wound, but you're unable to clean it away. The lower left picture is a picture of eschar. So it's that dark leathery tissue. Again, slough and eschar are non-viable tissues. And then the lower right picture. When we're talking about pressure injuries, which we will talk about in KSPN 107, we're talking about pressure injuries. This would be a deep tissue injury. This is over a pressure point. It kind of looks like a bruise. This would be a pressure injury, but it's non-stageable. So just to educate you on what some of those tissues will look like.